A very good evening to all the respected viewers of this special webinar. As you know that CCI is organizing a special COPD webinar series, a very relevant and important series. And today's topic is breath by breath, mastering inhalational therapy in stable COPD and other forms of COPD like COPD exacerbation. We all know that COPD is changing, the management of COPD is changing very rapidly, and we need to be very much updated because many of us practicing physicians, COPD is our daily bread and butter. And there have been significant changes in how COPD is being practiced, how it is being managed. More so, we need to be aware of the several diagnostic tests and the several other medicines which have come into the armamentarium of treating COPD. Dr. Raja Dhar sir is actually our moderator for this particular webinar, but sir is caught up and about to join very soon. He has informed us that he'll be joining us very soon. So I have taken up the mantle for him to introduce my August panel. We have a very special panel with us today. I have Dr. Manasi Gupta from Lucknow. I have Dr. Athul Francis from Kochi, and I have my new friend, thanks to this webinar, Dr. Nyrvan Baishya from MGM Mumbai. So, and all of us know who Dr. Raja Dhar sir is. Raja Dhar sir is one of the leading pulmonologists from Kolkata, and he is also organizing the CCI Con Kolkata, which is upcoming. And I am Dr. Ravi Dosi from Indore. Well, we have a very interesting discussion for you, preceded by two interesting webinars. One webinar I'll be presenting on management of stable COPD with inhalational therapy. Previously, we have had webinars on oral therapy and the pathophysiology of COPD, which were very well attended and very well discussed, which are available on the CCI YouTube channel, which Krishna sir and his whole team comprising of Narayan, Pradeep, Dr. CVK, and Dr. Atri, Dr. Shivani, and Dr. Kirit so painstakingly are preparing for being archived and being accessed for all pulmonology enthusiasts all over the world. Followed by that, we'll be having an interesting panel discussion on the inhalational therapy in stable COPD. So now I would like to begin with our presentations. I would like to begin with my own presentation of inhalational therapy in stable COPD. A very good evening to all respected viewers of the CCI webinar. Thanks, Dr. Raja Dhar sir, for that kind introduction. And thanks to Dr. Krishna sir, Dr. Narayan Pradeep, Dr. Atri, Dr. CVK, Dr. Shivani ma'am, and Dr. Kirat ma'am for organizing this important update on a very relevant topic, which we deal with on a day-to-day basis in our practice and is actually the bread and butter of any practicing COPD physician. I am Dr. Ravi Dosi, and now I would like to present this topic starting with a case scenario which we commonly see in our OPD day in and day out. A 55-year-old cook, smoker, a resident of Pahalgam, India, presents to us with progressive dyspnea, recurrent wheezing, chronic cough for which he has come to you several times, recurrent lower respiratory tract infections in which he has mucopurulent expectoration. On examination, you find bilateral monophonic bronchi, and on spirometry, you have a low FEV1 with a low FEV1 by FVC ratio and no significant bronchodilator reversibility. Our patient commonly presents to you with dyspnea, but along with dyspnea, he also presents to you with symptoms of anxiety and a fear of possible breathlessness developing just like that. This patient, when subjected to spirometry, can be classified as mild, moderate, severe, and very severe, providing he has an FEV1 by FVC ratio less than 0.7. Along with that, GOLD also recommends a set of patients who are not having symptoms, but who are having an impaired spirometry called as the PRISM patients, which if they are elderly, current smokers, females, they are also predisposed to develop COPD in the near future. These patients, after diagnosis, are assessed for their symptoms, and accordingly, they are classified into whether they are group A, group B, group E, or if they are suffering from severe symptoms, we classify them into group A, B, E, C for their exacerbation history, and we try to initially manage these patients with inhalation therapy and see if their treatment can be optimized using inhalation therapy, or you have to do add-on treatment like pharmacotherapy, oral, or risk factor management. You give them written action plans and try to manage their comorbidities. A patient is classified into group A if he has less exacerbations, less hospitalization, in which a single bronchodilator is preferred. If the patient is having more symptoms, then you prefer a LABA and a LAMA combination. And if the patient is having history of recurrent exacerbations, then you keep the patient on LABA and LAMA when stable. Otherwise, you consider giving him a LABA, LAMA, and ICS combination if the eosinophil count is more than 300. Inhaled bronchodilators form the most important group of patients for stable. Inhaled bronchodilators are the most important group of drugs used in stable COPD with level A evidence for most of them. Inhaled bronchodilators are always recommended over oral bronchodilators. Regular and SOS, SABA and SAMA improve FEV1 and decrease symptoms. SABA and SAMA combinations are preferred over SABA and SAMA individually. LABA and LAMA combinations are preferred over SABA and SAMA, giving immediate relief. They give improved lung function, decrease dyspnea, improve health status. They reduce the severity of exacerbations and decrease the overall number of exacerbations as well. Inhaled bronchodilators in stable COPD, always we should try to give lesser number of inhalers. Single inhalers are always preferred over multiple inhalers. And there is also the advent of a newer drug, ensifentrine, which improves lung function, dyspnea, and health status. This ensifentrine is delivered by a jet nebulizer over 5 to 7 minutes. So there is no need for high inspiratory flow rate or complex hand-breath coordination. Ensifentrine acts by bronchodilation, anti-inflammatory effect, and mucociliary clearance. Another group of drugs which is used commonly in COPD patients are inhaled corticosteroids. There are evidence A recommendations in favor of inhaled corticosteroids, like LAMA, ICS, and LABA combinations are preferred over LABA and LAMA individually, which in turn are preferred over ICS and LABA, and which in turn are preferred over ICS LABA used individually. Making it simpler to you understand is group E patients who are having a lot of exacerbations, we should prefer using LABA, ICS, LAMA combinations, as they are known to improve lung function, they improve health status, they reduce exacerbations, a significant mortality benefit is seen, and if there are features of asthma in our case, then inhaled corticosteroid should be there in the management. There is a role of eosinophils with an increased risk of pneumonia if you're using inhaled corticosteroids. At the same time, if your eosinophil count is less than 2%, then these patients are the one who are the more at increased risk of pneumonia as compared to those who are having eosinophil absolute count more than 300. Whenever you're initiating ICS treatment, see that the patient is not having repeated pneumonia infections, whether he is having a history of tuberculosis. If he is having a history of recurrent exacerbation and high eosinophil count, then that strongly favors the use of inhaled corticosteroid. If a patient comes to you who is already on LABA and inhaled corticosteroid combination, and the patient is not having any history of exacerbations, it's quite stable, we will just continue the treatment. If he is having a high symptom load, then we will change over from the LABA ICS to a LABA LAMA ICS combination, and more so if his blood eosinophil counts are more than 100. There are some basic principles for appropriate inhalational device. Whenever a treatment is given by inhalational route, there is education and training which has to be imparted, which the individual has to be individually tailored to his requirement, which can depend on access, cost, how it is prescribed, and the patient's ability and preference to use that. These instructions are very vital, with demonstration and a written protocol being given and the inhalational technique being demonstrated, and you ask the patient to teach you back. That would be the best way to understand whether he has understood or not. We should always see that whether the handling of the device is easy for the patient or not, what are the steps needed to prepare the device for operation, whether a force is needed to actuate that device, whether the inhalational technique for optimal usage is simple to use or not, what is the duration needed, what are the inspiratory flow rates that the patient generates, the respiratory flow acceleration, and the inhalational volume. You also look at the time and effort required for cleaning and maintaining the device. Smart technologies are available with sensors which help the patients to take their medicines properly. But it should always be a shared decision regarding the availability of drug in the device, the number of different devices, whether they want individually or combinations, what is the device size, portability, and cost. We should always avoid switching devices if there is no justification. If the patient is doing well on any particular device, then we should allow the patient to continue. Shared decision making is the most appropriate strategy for inhalational drug delivery. The patient's ability to perform the correct specific maneuver must be assessed. His cognition, dexterity, and strength should be taken into account. His experiences are paramount, and more important so, your familiarity with the device is also must. Dry powder inhalers are appropriate only if the patient can make a forceful and deep inhalation. We should check visually if the patient can inhale forcefully through the device, and if doubtful, opt for another device like a meter dose inhaler. Meter dose inhaler requires coordination in between device triggering and inhalational. There should be a slow and deep inhalation, and if the patient cannot do the same properly, opt for another device or opt for add-on spacers. Go for nebulizers, soft musk inhalers, DPI, or smart inhalers. LABA LAMA ICS combination has been shown to give mortality benefit in COPD patients, and we can see that several combination of drugs are available in MDI and DPI formulations, be they individual drugs, combination drugs, double or triple combination drugs. Even ensifentrine, which we have discussed earlier, is available in inhalational formulation. So whenever you're prescribing your drugs to a patient, see his symptoms, see the exacerbations or dyspnea, how he's progressing with your several scales, assess the inhaler technique, look if he needs non-pharmacological approach, and escalate or switch inhalers as per need. If the patient keeps on complaining of dyspnea and is on an individual LABA or LAMA, go for a combination therapy. Consider switching the inhaler device or molecule only if the patient is not having a better symptom control. Escalate if dyspnea persists and consider adding ensifentrine, though at present it is only available in the USA. Investigate and also treat for other causes of dyspnea if you have checked for everything and still the patient is not responding. If the patient is having recurrent exacerbations, definitely check the eosinophil count. There are several add-on molecules which you can give, like roflumilast, which is a phosphodiesterase inhibitor, azithromycin, which can be preferred in smokers, and dupilumab, which will be discussed about more detail in the next lecture. The ultimate goals for treatment of stable COPD are to reduce symptoms and reduce risk, and proper use of inhalational therapy is the best method for achieving that particular goal in stable COPD. Thank you very much for a patient listening. And now I would like to hand it over to Nyrvan for talking more about exacerbations of COPD and inhalational management. Thank you.
Good evening, everyone. I am Dr. Nyrvan. I want to thank the CCI team, Vijay sir, Athul sir, for giving me this opportunity. I also want to thank my previous speaker who has spoken so well, summarized the topic so well, and I would try to keep up with him, but I don't know if it will be possible. So let's start today. So my topic of discussion will be inhalation therapy since acute exacerbation of COPD. We'll start with a case. There is a 62-year-old male who is a known case of COPD. He is on treatment with formoterol glycopyrronium for the last 2 years. Now comes with the complaints of worsening symptoms of dyspnea and increased sputum purulence. So this elderly male had went to Delhi for some social function, and after returning he had worsening of symptoms. On examination to the emergency department, patient was tachypneic and tachycardic, and his SpO2 on room air was 88%. On auscultation, there was bilateral wheeze present. Patient appeared to be frail. He had no social support. He came on his own, and the patient had a history of severe exacerbation leading to intubation 5 years ago. So, as we manage this case, we will go ahead and discuss the treatment options in this patient. So, the definition of COPD exacerbation has been changing since the last 200 years. Initially given by Lennox 200 years ago, changed again by Antonison et al. And then this is the recent definition given by Goal 2025, which has been adopted from Selly et al. Article in the Rome proposal. So it defines as an event characterized by dyspnea and or cough and sputum that worsens over the last 14 days, which may be accompanied by tachypnea and or tachycardia and is always often associated with increased local and systemic inflammation caused by airway infection, pollution or other insult to the airway. So there is a symptom, there is a duration, there is a sign and the etiology. So all things, every time we see a patient of exacerbation of COPD, so we try to classify in these headings so that we can have a uniform discussion regarding the patients. So what are the confounders that can be present in a patient with COPD presenting in a similar fashion? Patient might have a pneumonia, patient might have pulmonary embolism. So in a history, we have to rule out this on the basis of history and rule out congestive heart failure, pneumothorax, effusion, MI or arrhythmia. So basically this is what we generally do. We do an ECG, we do an X-ray, and then if we suspect congestive heart failure, then we get a proBNP. So in our patient, we did an X-ray as well as ECG. In X-ray, we can see that there was hyperinflated lung fields as well as flattening of the diaphragm. Similar, we can see that in the ECG there was P pulmonale noted in lead 2, 3 as well as AVF. And we can see that there was no any fatal arrhythmias in this patient. So how do we classify exacerbations as per the Rome proposal? So they had defined exacerbation into mild, moderate and severe basis of dyspnea, heart rate, respiratory rate and resting SpO2 as well as CRP. And if we get a ABG done, ABG which is showing PCO2 more than 45 or pH less than 7.35, patient falls into severe. So in our patient had respiratory rate more than 24, heart rate more than 95 as well as saturation of 88%. So patient falls into the moderate category. And in this flow chart, we had already ruled out this of the differentials which might present similar. So what are the consideration for hospitalization and ICU care in a patient with hemodynamic instability, hypoxic or hypercapnic respiratory failure, patient presence with cyanosis? In this, intensive care treatment is required. So what are the indications for hospitalization in COPD patient? If there is increased intensity of symptoms, a marked increase in symptoms, there is new signs like pedal edema, as well as patient had altered sensorium, patient had signs of respiratory distress in the form of using accessory muscles of respiration, comorbidities like liver failure, heart failure should be kept in mind. And once the patient has been started on bronchodilator therapy, we should always assess the response, and if the patient does not respond, patient might require hospitalization. And we also have to look for airflow limitation. Patient had a history of previous exacerbation, frailty and insufficient home support. So all of this has been mentioned in the Goal 25. This has been added from my side. This has been present in the Lancet journal in 2022. So here in our patient had frailty, insufficient home support as well as severe exacerbation. So patient was considered for hospitalization. So this is the Rome criteria is basically used in primary care setting. In other hospitalized patient, we use this criteria. This is the same respiratory heart rate, same, but we use hypoxemia as well as PCO2. So any increase more than 50 to 60 is considered as acute respiratory failure, which is non-life threatening. But if it is more than 60 or pH less than 7.25, as well as patient requiring more than 40% FiO2 by venturi pass, patient is considered as life-threatening. So in our patient had, although this patient had respirator more than 24, but there was no change in mental status. So patient fell into the criteria of acute respiratory failure, which is non-life-threatening. So we would, in hospitalized patient, this score has not been mentioned in goal 25. So they would like to add some things which can be added. So in this patient, we had seen that patient had extended MRC criteria of 2. So patient have fall into this criteria, intermediate, where clinician judgment is required regarding disposition. So the principles of treatment, there are inhaled bronchodilators, supplemental oxygen, systemic steroids, antibiotics, adjunctive therapies, and biological therapies. This forms the backbone of treatment of COPD exacerbation. We'll focus more on inhaled bronchodilators, and we'll try to discuss small points which has come up in the recent literature review. So we'll discuss them in brief, but mostly we'll keep our attention on to inhaled bronchodilators. So in our patient, what should we use? Should we use Estelin or Duolin? Patient, to be reminded that patient is already on treatment with Forglin. So which should be preferred? So inhaled SABA is the mainstay of treatment. It is used primarily in COPD exacerbation because of rapid onset of action, and SABA can be available as a monotherapy in MDI as well as nebulizer. And SABA-SAMA combination in the form of Duolin is also available. So generally, when both are available, SABA and SAMA combination are available. So it is useful for our patients because SABA acts on beta agonist and SAMA acts on the cholinergic tone. So both has different action and has additive effects in our patients. So in terms of muscarinic antagonist, nebulized ipratropium can be used, which is available as well as in the available in a monotherapy as well as in combination with albuterol in Duolin. So it is generally not preferred as a monotherapy because it takes longer duration. It has a longer duration of action, but onset of action is much slower compared to Estelin or nebulized SABA. In patients who are on LAMA treatment, generally we try to avoid muscarinic antagonists like ipratropium. We generally go ahead with SABA because if there are more usage of ipratropium, there is a high risk of anticholinergic side effects. And because our patient is an elderly male, there is a high chance that patient might have chances of urinary retention. So how the nebulization is given? Generally in COPD exacerbation, we prefer nebulizers rather than MDI or DPI. So in which there are 3 forms, either a jet nebulizer or pneumatic or ultrasonic and mesh nebulizer. It is a jet nebulizer based on Bernoulli's principle. Ultrasonic nebulizer is based on electronic substances which vibrates and produces inhaled particles, and mesh nebulizer contains a mesh which also vibrates and produces nebulized drugs. So we have to keep in mind that in ultrasonic nebs, budesonide suspension should not be used. In recent ventilators, ultrasonic nebs are available, but with budesonide suspension, adequate inhaled drugs are not produced. So in budesonide, we generally prefer a jet nebulizer. So regarding what are the other treatment options, supplemental oxygen to target 88 to 92% oxygen either by nasal prongs or face mask should be done. So in this recent article in Emergency Medicine Journal, so they had used different targets, either 88 to 92, 93 to 96 and 97 to 100. So higher oxygen targets was associated with increased mortality. So as we know, in as per goal guidelines, 40 mg OD for 5 days is generally the 40 mg OD of prednisolone is generally the recommended treatment. But we'd like to discuss further beyond goal. So in a recent study, the Corticop study, they had used eosinophil guided therapy, in which they had classified the patients at eosinophil more than 300 and less than 300. In patients with eosinophil more than 300, they used steroids, and less than 300 they did not. So there was no difference in outcome, and there was reduced duration of use of systemic steroid. So it has been seen that systemic steroids, although we think it as a benign when you use for 5 days, but it is associated with increased infection as well as increased incidence of sepsis. So, in this article, in recently published in European Respiratory Review, they had seen that in inhaled steroids versus systemic steroids, there was no differences in outcome in patients in terms of treatment failure rates, breathlessness, post-treatment scores, or adverse effects. But there was fewer adverse events. So, in our patient, is antibiotic indicated? If yes, then why? So in our patient had increased breathlessness as well as sputum purulence. So patient meets the Antonsen criteria. So patient was started on antibiotics. So what antibiotics should we start? So generally, third generation cephalosporin or levofloxacin is the recommended treatment as per ATS. But in our country, as we know that levofloxacin is used in the treatment of MDR cough. So ceftriaxone is a reasonable alternative. However, in patients who have a risk factor of pseudomonas like bronchiectasis, prior history of colonization of pseudomonas, in those patients, anti-pseudomonal antibiotics should be started in the form of ceftazidime or pictas. Other adjunctive therapies, it is use of IV magnesium sulfate. They had seen that use of magnesium sulfate 2 gram over 20 minutes in emergency department. There was less odds of hospital admission in those patients. So last topic we come to is the use of biologicals. So use of biologicals in asthma is very widely accepted, but is it in COPD? So in eosinophilic COPD exacerbation, they divided the patients into 3 groups where they divide into prednisolone or benralizumab monotherapy or benralizumab plus prednisolone, in which they had seen that use of benralizumab was associated with less treatment failures, as well as there was less mean difference in change of VAS favoring the use of benralizumab. So on day 5 after the treatment, so me being always nervous, me looking at the patient like Sharman Joshi, and my patient being confident that he is doing well, and this is the reaction of the patient. This is what it remembered, that patient is saying all is well to me, and we discharged the patient on day 6, and patient is currently doing well, and he has come to the follow-up last week. So what are the take-home message? So I have just passed my exams. So I know that this anyone who is appearing for exams, this Rome proposal is the hot topic. So anyone going for the exam, last minute topics is to go through the Rome proposal, and nebulizer devices, how it is used, principles of use, we also have to know. And when Saba is used, when Saba Sama combination is to be used, that is what we have to know. And regarding the use of benralizumab also, if in the future this might be applicable in our patients. Thank you.
Hi, good evening, folks. My name is Dr. Raja Dhar. I'm sorry I'm late in joining the meeting, got stuck in traffic, but absolute pleasure to be with all of you today and doing a CCI Thursday meeting again. I've not done it for a while, and it's an absolute pleasure to be there. A big thank you to Krishna Bhai, to Dr. Ravi Doshi, who's here already, to Dr. Vijay Chandram Chetty for having asked me to facilitate, moderate this very important session. I heard the tail end of Ravi's talk and all of Nyrvan's talk, and big congratulations to the youngsters for having done a very good job in describing two bits of COPD, the stable COPD and the exacerbating COPD in the way of case references, case discussion. A warm welcome to Dr. Manasi Gupta and Dr. Athul Francis, along with, of course, Ravi and Nyrvan, who are here already. What we'll do over the next 1 hour is to go through various facets that have been touched upon by Ravi and Nyrvan but also look at other facets which are emerging as areas of importance. And what we'll try and do in this 1 hour discussion is to try and give you clinical pearls, try and give you tips in day to day clinical practice for patients that you see on a day to day basis about inhalation and COPD. That's what the ambit is. All of you know that inhalation therapy forms the backbone, forms the spine of management of airways, any airways disease, including COPD. The fact that the device and the drug are of great importance, the fact that we are finding an increased role of nebulization in the management of COPD, of course, in the exacerbating state, which Nyrvan described very aptly, but even a small proportion of patients benefit from use of nebulization at home, and we'll discuss these facets. You also know that when we talk about COPD, unlike the time when I got trained as in respiratory medicine as a postgraduate trainee, I was told that it is only smoking which causes COPD. Times have changed, and we have now multiple etiologies, multiple environmental factors which cause COPD. And maybe, and we'll discuss that as a part of this meeting today, the management will depend on the environmental trigger which causes the COPD. And we'll try and tease aside how things are different when you talk about smoking versus non smoking COPD. We'll also talk about various ways in which drugs can be delivered, the single inhaler triple, the multiple inhaler triple therapy, etc. And hopefully, we'll get your questions. I can see my good friend Dr. Trideep Chatterjee has started putting questions into the question box already. So now is your chance. Go ahead and put your questions in, and I'll take some of the questions as we go along. And of course, we'll take some of the questions at the very end. So, seatbelts on. We'll start off with Manasi. Manasi, we spoke about two cases in the two lectures. We spoke about someone with stable and the other with an exacerbating phenotype of COPD. I want to ask you, you have two patients, one who doesn't exacerbate but has a lot of burden of symptoms, who probably has an MMRC3 or an MMRC4, has a CAT score which is high, versus another patient who is reasonably well otherwise, well in the way of exercise tolerance, well in the way of not coughing all the time, however, exacerbates about 3 to 4 times in a given year. As far as prognostication is concerned, when you speak to this patient, when you speak to the family, which do you think has the worst prognosis, or do you think they are similar? Because this will orient us as to how you manage these patients going forward. What is the intensity of therapy that you give to these individuals? So over to you, Mansi.
Thank you, sir. So, very pertinent from the previous talks about stable and exacerbating COPD. So now, previously, the things were more about classifying COPD just based on the airflow limitation that the patient used to have. But now we are moving towards treating the patient's symptoms, then the exacerbation risk, and how the quality of life, and eventually how is patient going to survive over the long term, as you said, the prognosis. So now we aim at kind of stratifying the risk of a patient based on the symptom burden and exacerbation risk. So those patients who are definitely exacerbating more times of the year, despite the kind of airflow limitation they have definitely got a more worse prognosis in terms of, because every exacerbation lands a patient with fall in lung functions, and eventually those lung functions take a lot of time to recover. Maybe it may, if the patient has, as COPD is, the small air inflammation will take time to settle down. So exacerbation puts a patient sort of, a patient steps back a little from the trajectory that is moving on. And that is why every exacerbation, those patients who are exacerbating more than 2 times a year, those patients who are going on invasive ventilation or non-invasive ventilation for an exacerbation, who is frequently exacerbating, again, the chances of him landing into another exacerbation or getting hospitalized are much higher as per the data. So these are the patients who definitely have, in terms of the prognostication, I would say, they will be more difficult in terms of the long-term survival, and they need more intensive therapy. That, what else can be given to these patients over and above the basic drug that we are targeting, bronchodilator therapy for COPD. So All COPD patients are receiving bronchodilators, either single or dual. And then there are certain patients who are moving on to triple therapy. So this is where the difference between symptom burden and exacerbation burden will come into play.
Sure.
So
Sh- Sure. So I think we lost Atul there. I was going to ask. Great. So I think you raised a very important point, and we'll come back to this multiple occasions. The fact that exacerbation is the most crucial factor in all chronic lung diseases, but especially in patients with COPD. Symptoms are important. And Atul, we are speaking now about gold B COPD, right? So let's sort of specify gold B COPD. So high CAT score, high MMRC, however, less exacerbations. These patients also are at high risk. We know these patients also go on to exacerbate on occasions. So let's your comments about this symptom predominant disease, which might exacerbate, and then I'll take you into etiotypes after, where we'll discuss etiotypes briefly and then go into each of these etiotypes individually as we go along. Atul, all yours.
So basically, as we told, there's a stable COPD in which his symptoms are stable, he is not exacerbating. And thirdly, there is minimal lung function decline. Then there is another category called exacerbation. Now there's a clear-cut definition for exacerbations as well. So any COPD patient at any point in time can go into an exacerbation, providing there is a triggering factor like an infection, or there is exposure to smoke or industrial smoke or any pneumonias or anything like that. So whenever you are talking about exacerbation, there is worsening of symptoms, especially there is dyspnea, there is cough, and mostly associated with purulence. And now they give a clear-cut guideline that it should be less than or equal to 14 days, and patient will have symptoms like tachycardia, tachypnea. And the last part of exacerbation is that there is a factor which is causing the exacerbation, like as I told, like a sudden exposure to smoke or an infection like that. So basically, whenever, even if you're having a stable COPD patient, our main intention should be to prevent an exacerbation. What can be done to prevent an exacerbation? Although it is not possible 100%, so we should be trying to prevent through vaccinations and all that to prevent exacerbation from occurring. Because even when you're looking at the risk factors for exacerbation, one risk factor which always stands out is a previous exacerbation. So a previous exacerbation is always a risk factor for a future exacerbation. So any stable COPD, no matter how stable they are, can go into an exacerbation at any point in time. So it is basically important to identify the cause of their COPD and treat their COPD so that they don't go into an exacerbation.
Sure. So fair points, Atul. So I think so I'll tell you what I was trying to get to when I asked these questions to both of you. So we've just published a paper in Lancet yesterday, which looked at bronchiectasis, stable versus exacerbating, high symptom burden versus exacerbation. And it was looking at low dose azithromycin and its role in the second category, which is when there is a high symptom burden. And we found that high symptom burden disease, low dose azithromycin prevents exacerbations in a way which is similar to what you would get in the exacerbating population of COPD. So the reason I say this here is simply because while we all know that exacerbation, like Manasi said, is the single most important factor in the disease course in the lifetime of a COPD patient, high symptom burden seems to be also equally at high risk. And like Atul said, trying to prevent exacerbations in this population is important. And I was hearing Nyrvan's talk where he spoke about eosinophils. So that's the category of patients where you do eosinophil counts. So in a stable patient, if you find that the eosinophil count is high, it would indicate that these are patients who might go from gold B to gold E in short period of time, and your focus of targeted treatment, maybe inhaled corticosteroid in this category of patients, is going to be higher, even though they don't belong to gold E. And that's emerging evidence, and that's important for all of you clinicians who are listening to us today. Let me bring Ravi into the discussion. Before that, I haven't got into etiotypes. So maybe Mansi, you start off a little bit about the concept of etiotypes of COPD, and then maybe we'll talk about it in greater detail as we go along. What's etiotypes? What are the different etiotypes we have? And a quick comment from Atul after. Mansi.
So etiolotyping basically is very suggestive. We know etiology means causes. So etiotyping a disease means that we're trying to look into the causes and the mechanisms of the disease. So primarily, why this concept is slightly new in COPD taxonomy, because earlier COPD was thought to be a primarily smoking related disease. Now that over the time with research going on, we have found out that COPD is kind of heterogeneous in presentation as well as the kind of risk factors that are underlying to COPD. So now the current recommendation is, try to find out the cause and the mechanism behind COPD. So cause would be something like a clinical phenotype of COPD with the risk factors that the patient is presenting with, which could be a genetic risk factor like an alpha-1 antitrypsin deficiency. So you call it COPD-G. And then if you have infections like tuberculosis, so it will be called COPD-I. Smoking related will be called COPD-C. So there are different taxonomies, and they can be a mixed phenotype, COPD-M, where you are, having too many factors, and of course, this phenotype will behave differently. So this, etiotyping is important because ultimately, when you're trying to find a cause, like Sir has already said, you will also delve into endotyping of a disease based on what kind of inflammation you're dealing with, and that would sometimes, with the available therapies right now, would add something to the management of a patient. That
Yeah,
is basically trying to find out eosinophilic phenotype or endotype, as you call it. Yes, sir.
sure. Sure. So that's the concept. Very nicely put, Mansi. So the concept is that you're trying to divide COPD. So COPD at the top, like you do in ILD, you try and find out the cause of interstitial lung disease. Similarly, in COPD, you're trying to find out the trigger, smoking versus biomass versus asthma versus post TB. You're trying to dwell into etiologies. And Atul, how does that? The discussion today is about inhalational therapy in COPD. So how is that relevant to inhalational therapy then? Why are we discussing it in the context of inhalational therapy?
So whenever we are coming to the inhalational therapy, sir, so basically when we are talking about etiotypes of COPD, as ma'am rightly told, it helps us in identifying a causative agent, why it has happened. So secondly, there is a phenotyping called COPD-A, when there is a COPD asthma phenotype. So asthma, as we all know, because there is a bronchial hyperresponsiveness, steroids are needed. So such cases, if we are using inhalational therapy, you can use a combination of LAMA, LABA, and ICS. So that is where it will be helpful.
Yeah.
Similarly, other causes also, it's important to identify whether the patient has an alpha-1 antitrypsin deficiency because it's a multisystemic disorder. It can affect your liver as well in later stages. So sometimes what happens is we are just treating the COPD with inhalers and we are not going into the root cause of what the why the COPD has occurred. So that also can be pretty useful. And also in many cases like bronchiectasis, sometimes when there is a COPD and sometimes we give inhale steroids, that in itself can cause an exacerbation or bacterial
Yeah.
colonization in some patients, and even NTM patients, to prevent NTM in such patients with bronchiectasis. So that is where the cause of COPD, why it has occurred, or the etiotypes of COPD can be helpful, especially when we are giving inhaled medications.
Yeah. So Atul, you're a man after my heart. You brought in bronchiectasis into the discussion early. Thank you. So the point that I want to make before we go on to asking Ravi the next question is that if you think about non-smoking COPD, think about a disease where there is a more eosinophilic airway, akin to what you would get in patients with asthma. When you think of smoking-induced COPD, you think about a more cellular or a neutrophilic airway, where the damage is more in the lung rather than being in the airway, and hence giving inhaled corticosteroids in this population of patients is going to be less useful. There's more complications, as Atul and Mansi said. So post TB, you would be hesitant about using an inhaled corticosteroid in this population of patients. Bronchiectasis, it's probably the same. And we'll come back to these. But important carry home message, when you prescribe for your patients with COPD, along with what exactly the disease where the disease lies, the spirometry, the burden of symptoms, etc. Also think about the etiology. Also think about whether it's an M or not. Like Mansi said, is it mixed? Is it just biomass related? Is it just smoking related? And correlate these factors before you go on to do your prescription of the inhaled drug. That's why etiotypes are important, not just for the epidemiology of the disease process, but also about management, especially with inhalational drugs. Let me bring Ravi in. Ravi, I'm a great admirer of the way you do patient education. You know, the videos that you put out. always look out for them and then look at them, because the messages are loud and clear. So I'm asking you a question which is very basic, but I think all of us clinicians on this panel and outside people listening to us would want to ask. So you have patients with COPD who have a predominant cough, bring up sputum. And then you have people who do not have such a lot of cough, but are breathless. And then you have a degree of overlap in between. So when you prescribe for your patients, of course, you look at spirometry, you look at burden of symptoms, you look at the blood eosinophil count, but do the symptoms matter to you? Does it someone who's coughing less breathless versus someone who's more breathless, coughing less? Does it mandate the way you prescribe medications, inhale medications for these patients? Ravi.
Well, definitely, sir. I think the crux of the whole discussion comes down to this only, that whom you prescribe what. Well, if you have predominantly cough in a COPD patient, then we can easily imply that these airways are more inflamed, they are filled up with more mucus, and there probably might be relatively more of an asthmatic or allergy component to his cough. And as you told previously, the other category, which is dyspneic, will be having more of bronchoconstriction, more of alteration in his lung parenchyma, and there will be more stiffer airways comparatively, more neutrophilic inflammation. So whenever we see a patient who is having non-infective cough, then I would feel that we would be more correct in advising inhaled corticosteroid containing combinations, provided we have ruled out infection properly. At the same time, if we have a patient who is predominantly dyspneic, now if the patient is dyspneic, immediate relief can only be given by SABAs and SAMAs. And at the if you are planning for this chronic management, then giving anticholinergics to that particular patient in the form of LAMAs would be much better. If there is an overlap, if he has everything, then definitely the triple combination of LABA, and ICS with a higher eosinophil count justifying our use will be what we would be looking at.
The lovely answer, Ravi. So very, very important points brought up by Ravi. And I think this is something that everyone can do. Not all of us have access to things like Pino, for instance. However, all of you have access to a good history. So cough, purulence, exacerbations, multiple episodes. Think of airway inflammation in the way of eosinophil inflammation. Think of inhaled corticosteroids in these patients. More of breathlessness, less of cough, less of phlegm. Think of the emphysema predominant disease, and bronchodilation would be the backbone of treatment there. You would think twice before prescribing inhaled corticosteroid in that cohort of patients. And then again, Ravi spoke very nicely about the overlap phenotype, where you probably would use a triple. But that's broad. We'll come to sort of trying to nitpick and decide exactly what therapy as we go along. So I'll come to you, Nyrvan. Nyrvan, we've spoken about this, but I want you to sort of clearly spell this out for this category. We spoke about etiotypes, and we also spoke about bronchiectasis. Athul mentioned bronchiectasis briefly. So in these two categories, when you have a COPD, which is post-TB, so your so-called TB-associated obstructive pulmonary disease, or TOPD, and you have the BCOS phenotype, which is the bronchiectasis COPD overlap syndrome phenotype. What do you think of when you prescribe inhalational therapy in this population of patients in the stable state? We're not talking about exacerbation just now, but in the stable state, what are the bits which will go on within your head, which will decide the prescription for these two phenotypes of patients? Nyrvan.
Sir, in post-TB lung disease or TOPD diseases, there are significant amount of bronchiectasis as well. So it also fits in the criteria of BCOS as well. So in those patients, in them, there are high, because bronchiectasis, there are high chances of infection. Recurrent infections are much higher compared to COPD patients. So in those patients, prescribing a patient inhaled corticosteroids will be, I will be very careful in doing so. Unless patient fills all the criteria more than 300, only then I would consider. And still then, I would like to go to the CT scan of the patient and see which is the predominant type, whether the airway, whether the parenchyma is involved, or more bronchial thickening or bronchiectasis is involved. If in a patient with more bronchiectasis, there will be high chances of recurrent infection. So in those patients, inhaled corticosteroids will be relative contraindications for my side.
Yeah, lovely answer, Nyrvan. Love the way you said that. I've got a couple of points to add, especially about the bronchiectasis bit. So there's about 20% of patients in India and globally who have eosinophilia in the peripheral blood with an absolute eosinophil count of above 300. So that's the rare phenotype of bronchiectasis, where an inhaled corticosteroid actually helps in reducing disease progression and avoiding exacerbations. In the remaining 80% of the population of bronchiectasis, you're treating, as everyone on this panel has said, you are treating a neutrophilic inflammation where giving inhaled corticosteroids are actually going to cause damage as compared to causing good. This data has not been established yet in post TB, but probably something of a similar ilk also holds true in your patients with post TB, where you will have a predominantly neutrophilic inflammation of the airway. And if you have airway eosinophilia, you could prescribe inhaled corticosteroids with a lot of caution, making sure that you look towards a relapse of TB when you follow these patients up in the long term. So that's about bronchiectasis and post TB. And Nirvan, that was very nicely put. Let's go forward and we'll come to Athul next. Athul, we have spoken about this in different forms. I think Ravi very nicely described about how symptoms in the way of cough expectoration versus breathlessness and how you balance your inhaled medication. Let's now change these symptoms of बहुत सांस फूलता है, बहुत खांसी है. Let's go on to try and be objective. Numbers. So we have the MMRC and the CAT, which is advocated, it's validated. These questionnaires are validated in India. It's available in 20 different languages. So would you advocate using these questionnaires in your patients in the OPD when you see them? And if so, how is it different using these questionnaires versus asking people to feel well? No, I don't feel that well, or I feel okay, or I feel very good. Do you think there's a difference when you use these questionnaires? And again, please tell us in the context of prescription of inhalational drugs or change of prescriptions on follow-up when you speak about these questionnaires. Atul.
So basically, whenever we are talking about scoring, there is one MMRC and there is a CAT score. So MMRC, from the inhalational point of view, treatment point of view, it is important. But on top of that, MMRC is the way in which you can diagnose a case of COPD as well, because there will be a slow increase or progression of breathlessness over time compared to asthma when he usually has a sudden worsening of symptoms. So MMRC, basically you have grades, and even Gold describes it as any MMRC which is greater than or equal to 2 is something which you call a severe breathlessness. And coming to the next part, which is your CAT score, which is a 8-point questionnaire, and CAT score is something in which the score is greater than or equal to 10. That also is something that suggests a severe breathlessness. Earlier, there was a St. George respiratory questionnaire. So CAT score is kind of, they say, it has been matched for SGRQ, and SGRQ greater than or equal to 25 is almost equivalent to CAT score greater than or equal to 10. So that is where it is. So that is how you classify. Again, basically, you have your spirometry in which you look at the FEV1 values and you classify it into mild, moderate, severe. But sometimes what happens is if that PFT is not available at that point in time when the patient is coming to you, this MMRC grading can be very, very useful. So on top of that, when we are using the table in which you have the A, B, and E, depending on which you prescribe your inhalational medications, there your MMRC score as well as your CAT score is important. So that is how we, irrespective of the exacerbation point, because exacerbation goes in the y-axis. On the x-axis, you have your MMRC and CAT score. So A and B is like that. So if MMRC is less than 2, that is A, and greater than or equal to 2 is B, and similar with the CAT score. So there also, so even in your prescription of medications or inhaled medications, that CAT score and MMRC is important. And the thing is, whenever we are talking about asthma, you look at your nocturnal awakening or greater than 2 times inhaler use or nighttime use of inhalers. But in asthma, I think it's more of the MMRC score, and even CAT score is important, because whenever you are classifying an exacerbation, that they describe it as there is a worsening of the symptoms, worsening
Sure.
of worsening of your expectoration or purulence in your expectoration. So there also ideally you need a baseline as to how he was before to say that he is exacerbating currently. Just
Sure.
on the symptom base, I'm not talking about
Yeah.
the signs and all that, all the tachycardia, tachypnea, but just on the symptom base, it's always, even when you're telling your clinical history, you always say there is increased breathlessness. You don't say that it's breathlessness. It's basically increased breathlessness from your baseline breathlessness, which you already had. So that is where this CAT score and MMRC score is always important.
Yeah, great answer, Atul. So, uh, crucial carry home message for the audience about these questionnaires. It is useful to measure these. It is useful to measure these because it's important to quantitate breathlessness when you talk about burden of disease. In any chronic disease, we are talking about COPD today, but any chronic disease, it's important to quantitate it. The other important factor, which is sort of specially true about the CAT score because it's more detailed, is that when your patient comes back, so initial attendance to clinic, suppose you've got someone with severe COPD, CAT score of 25, you send them home with triple therapy, they come and other sort of relevant treatment, they come back to you, get the CAT score done, and you find that the CAT score is 17. That's reasonable evidence that at least the symptom burden in these patients have improved, and this is objective evidence that your patient has responded to treatment. There's another aspect which I think makes the CAT score very important. So maybe you have someone who's got an overlap of chronic bronchitis and emphysema. You give the patient a triple, the patient goes home and comes back. The initial CAT was 25, now the CAT is 23. It's not much of change. However, when you ask the patient, they tell you in the walking up an incline basket or your activities of daily living basket, as in the question, there's a worsening of breathlessness, whereas the cough, the phlegm in the chest has gone down. So you know that the airway component is better with your treatment. However, the breathlessness component, the parenchymal component, is probably worse, which is why you need to tailor your treatment accordingly. You need to maximize bronchodilation even more in these patients rather than targeting the airway. So that's also something that the CAT tells you, which is why I think the CAT is a great tool to try and quantitate breathlessness at baseline and then look for response to treatment. There's a question in the question box. I'll quickly take this, which is from Pradeep, who asked the question which I asked Nyrvan a little while ago about real life evidence of TOPD patients group E, high eosinophil count. I would be scared to give them ICS. However, like I said, we've got good evidence now. We've published now Indian data that these patients who have a high eosinophil count, the eosinophil count overrides the risk of flaring up of infection in patients who have an absolute eosinophil count of more than 300. So it's still extrapolation. It's not really bronchiectasis we are talking about. You're talking about TOPD. But we feel we have studies on the annual, but we feel it's probably going to be safe in this population of patients also. I'll come back to your questions, other questions as we go along, Tridipda. Let me come back to Nyrvan. Nyrvan, straightforward question, but I want a clear answer from you. What are the goals of treatment when you treat someone with stable COPD? What is it that gold mandates or you mandate for your patients when you treat your patients with stable COPD? What endpoints?
Sir, it is a very pertinent question to our topic. So the first important thing is that smoking cessation should be the primary goal. Second thing is to improve the patient's symptoms, relieve the patient's symptoms, try to improve the exercise tolerance of the patient. Then next, we will try to prevent exacerbation either by using inhaled corticosteroids as well as ma'am has already mentioned regarding the use of inhaled corticosteroids as well as the etiotypes binding in similar fashion, as well as in the last but not the least, till now it has not been discussed here, but palliation has to be also discussed when the patient is in a stable state, so that when the patient comes in exacerbation state, at that time regarding the goals of treatment, that at that time cannot be discussed. So palliation also has to be done and when the patient is stable.
Sure. So Nirvan, you bring a very valid point about palliation, and I think we'll discuss this briefly towards the end, and maybe hopefully there'll be questions on palliation. But the broad outline when you set out to treat these patients is A, to try and make sure that you reduce burden of symptoms, B, to make sure that you reduce exacerbations or prevent exacerbations, and C, in trying to make sure that the comorbidities that you have around the disease are also well controlled, because we know that the cardiac risk factors feed into respiratory and so do multiple, the osteoporosis bit, We know COPD is a multi-system disease. Hence, the comorbidities basket also needs to be controlled when you speak about trying to set goals. The palliation, I think, is very important, but we'll come back to that later. Let me go to Manasi next. Manasi, we are speaking about inhalational treatment today. However, we know that there are multiple verticals when you set about trying to manage someone with COPD. So, broadly, before we enter inhalational treatment, tell us what are the different verticals, what are the various aspects of management of COPD broadly that you would want to remind us of before we enter inhalation.
So I'll obviously everyone is aware of the goal guidelines, but I would say that how I'm going to whenever a patient is walking in, how we are doing it. So as the goals have been outlined by Nyrvan and you, sir. So first thing is what is the symptom burden, and we are going to target that. Exacerbation is second aspect, and third would be supportive therapies, as I call it. That will be about a comorbidity assessment and other things also. So for symptom control, first thing is we have to the primary therapy for COPD patients. In all the patients, bronchodilator therapy remains the mainstay of treatment because most of them that is how the diagnosis is made. Patients are having airflow limitation, and that is why they are symptomatic. Amongst bronchodilators, we will discuss in detail later on that what all we can give to the patient. The second aspect of pharmacotherapy would be to, in my opinion, I would also be interested to know whether this patient would need inhaled corticosteroids at any point of time. The third aspect that for symptom control, whenever a patient is coming to a tertiary setup, so for symptom control, we also need to know the resting saturation of a patient. These patients may sometimes need oxygen therapy that should be evaluated at the outset using a pulse oximeter or maybe a APG analysis. In certain patients, actually, in all the patients, pulmonary rehabilitation should be discussed at the outset because this will help in all the aspects, symptom control as well as the quality of life, and eventually the exacerbation risk also. For preventing exacerbations, that is the second goal of our treatment. At the very out, whenever we are seeing any patient of COPD, mostly the group A category doesn't land up at tertiary care setups. They're mostly with primary physicians. The other groups, vaccination is a mandatory thing to prevent exacerbation, and there are many facets what all vaccinations can be given. So pneumococcal and influenza is the most we should all be giving our patients these two at least, but the other vaccines are also recommended with evidence B recommendation as per gold, so we should consider whenever it is feasible. And apart from that, in certain patients, when we're evaluating these patients, the comorbidities part that sir has said, at the outset, we mostly in advanced cases of COPD who are having exacerbations, a CT scan analysis and echocardiography for pulmonary hypertension, and other nutritional factors, they have to be looked simultaneously into. So these are the broad aspects where I'll be starting off in my patient at the very outset. These are the limbs that I'll be starting on.
Grand. So very nicely covered. I'll sort of pursue a little bit more, Mansi. So what about source control? You're not going to speak about source control.
Yes. So cause so basically, if we are patient's history will tell us what kind of thing is there. So smoking cessation, many of the patients are smokers, but believe me, sir, over the time I have realized that many of our patients are non-smokers COPD nowadays, and this biomass is coming out as a biggest risk factor in my setting where I am sitting. So mostly women who are having COPD have this hidden history of biomass fuel exposure, which we have to address, obviously. And other causes, certain we evaluate young COPD on the lines of other things also. So if a patient who's young, less than 40 or 50 years of age, then and smoking is not the primary risk factor, smoking or even exposure to environmental pollutants, in that case, we'd be going a step further in evaluating for other possible causes. So that has to be addressed.
Yeah. So we've gone from smoking cessation to source control. That's the reason what Mansi said. The fact that it's not just about smoking. It's about a lot about non-smoking COPD in India today. That's not to say smoking does not cause COPD. It's to say other causes equally cause COPD as smoking does. So it's important. So I think we've ticked the various areas. We'll get into inhalation and I'll bring Ravi back into the discussion. So Mansi just said, Ravi, aptly so, that we don't really see a lot of gold A COPD. However, there's an increased focus on trying to diagnose COPD early. The terminology early COPD, the terminology of PRISM are gradually coming into being, and the whole focus is catch the disease early so that you can prevent disease progression rather than catching the disease where palliation, as Nyrvan was speaking about, remains the only motivation for treatment. So gold A COPD, what drug, Ravi, if they land up with you, and what's the evidence between the various drugs that are available? Sort of clear message for gold A COPD management, Ravi.
Well, sir, like you told, Gold Day is practically all of that we want to target. Actually, all of the aging population, all of the so-called undiagnosed COPDs, usually unsuspectingly present to us in as Gold A, who have an MMRC of 0 to 1 and a CAT score less than 10. The recommended is that they should be on any bronchodilator. Ours is an inhalational bronchodilator webinar, so I'll be supporting more of SABA and SAMA. Although previous webinar people also talked a lot about oral bronchodilator in this particular group. SABAs and SAMAs are recommended, but we more tend to use LABAs and LAMAs because mostly we find patients overlapping of group A, group B with some symptomatology. Evidence supports the use of LAMA over LABA if you want to use a single agent. There are several studies, and if you put them all together, they say that LAMAs offer a overall lower exacerbation rate. They have a lower serious adverse event profile. You have more serious adverse events with your other LABAs like tremors and cardiovascular problems, and overall lamas or the anti-muscarinic or anticholinergic agents, they give a higher trough FEV1 value as compared to other agents used singly. So if you are starting in a group A COPD, then it would be preferable to go with an anticholinergic or an anti-muscarinic agent.
Sure. So very nice messages. So let's sort of put them as headlines. So inhalational therapy preferred over oral treatment. That's the first header. Second header, oral treatment to only be given as add-on treatment, not as a replacement for inhaled therapy. That's number 2. Number 3 is long-acting agents are better than short-acting agents, irrespective of whichever stage of COPD that you talk about. So long-acting agents come before short-acting. And then the last very clear message that Ravi gave, which is LAMA preferred over LABA, because multiple studies and even a meta-analysis has shown that the propensity of LAMA to reduce exacerbations is greater than the exacerbation reduction that LABA causes. However, the combination, which we'll come to in a moment, causes greater reduction as compared to any individual bronchodilator. So those are headers, messages that should be loud and clear. I'll come back to Manasi again. Manasi, when you choose a inhaled medication for gold B COPD, when do you decide, okay, this patient I'll put on a single bronchodilator, this patient I'll put on a dual, versus, okay, let me start off with a single, I'll review the patient in 3 months' time, and if the symptoms are no better, I'll go to a dual. What's your approach?
So I think you've answered, sir, the question yourself. So basically, in Gold B, we're seeing the patients who are MMRC wise more than 1. I mean, it's 2, and CAT score is also more than 10. So both these assessments are important. For me, monotherapy versus dual therapy will be a lot to do with how the patient is behaving in terms of his symptoms. So if the symptom burden is high,
I think we've lost Mansi for a second. Let's sort of go on. Mansi will, I'm sure. Mansi, can you hear us now?
Yes, yes, sir. So the thing is that what I was saying, dual, so the difference between monotherapy and dual therapy will be dependent on patient's needs and how he's behaving clinically. If the symptom burden is little lesser, a monotherapy would be preferred with LAMA, as you've already said that if you have to choose between, anyways, LABA monotherapy is not really available, so LAMA anyways is preferred. And there's already a lot of scientific evidence to favor LAMA over LABA also. But personally, if a patient's CAT score is crossing 20 and his dyspnea is much higher, and there are some exacerbations here and there, not very frequent, then probably a dual therapy scores over a single monotherapy in such patients. So it will totally depend on patient to patient basis. Just classifying Gold B will not make much of. We can go for certain patients who are borderline, like you said. Would you like to be sequential in certain patients? Yes, of course, we like to be sequential in certain patients. You start off with lama monotherapy. Certain patients would do very well with that, and their symptoms and exacerbations are gone. But some will progress or they are not improving. In that case, maybe then you decide to give a dual therapy. So it will totally be patient tailored, sort of.
No, very fair points, Mansi, and I think you made it much clearer than what I briefly mentioned. So the Indian guidelines for COPD are about to be out, and one of the biggest controversies we had was on this particular point. You start off with a mono. So most of my colleagues felt that starting off with mono should be compulsory, and then you go to dual. I still feel, and you will, when you read the guidelines, find this as an addendum that a few people did not agree with starting with a mono in all patients. I feel, just like Mansi said, it depends on the symptom burden. That's why you're doing a CAT, that's why you're doing an MMRC. If you did everything the same for everyone, you're probably being depriving patients who can actually have a reduction of disease progression by having a double, giving them a single, allowing the disease to progress to an extent, and then giving them the double after. So I think the numbers are not clear, but slightly above 10 CAT score, somewhere between 10 to 20, you might want to start off with a single. Anything above 20, lots of cough, phlegm, etc., you would want to start off with a double or even a triple in these patients rather than just opting for a double. I mean, that's the way you would think. The eosinophil count would also count in. And this is an important thing to remember for all of us, for all of you. That's an important question, nicely answered. Let me go to the next one and I'll come back to Athul now. Athul, how do you choose the right device? And we haven't spoken about devices yet, but I want your inputs and maybe others can chip in. How do you choose the right device for a patient? And how would you position an MDI versus a DPI versus the more recent breath actuated inhalers in patients with COPD? Atul.
So choosing a device, even the goal guidelines describes it should be firstly we have to look at the patient profile, his symptom burden, his flow rates, etc. And secondly, it should be a shared decision as well. So that is something that gold implies on that. Sometimes we prescribe something and the patient is not ready to take that sort of an inhaler. So that is something which always happens. So firstly, we look at the patient profile, how his flow rate is, how his coordination is, whether he has any disorders like a Parkinson's disorder or a CNS condition, which makes sure that he doesn't get the required coordination that is required to use an MDI with spacer, and whether he is not able to generate the flow rate that is needed for a DPI. And even actuated inhaler also, whether they are able to use it properly. And above all this, it is always important that whenever you are starting a device for a patient, you make sure that you demonstrate it to the patient on how to use it properly. And
Sure.
and even when you are starting a DPI, make sure that he has the adequate flow rate to generate. Most often, what happens is we are getting COPD patients. Many of them report to us during exacerbations. It's not like many of them are detected in OPD. Some of them continue to have that breathlessness and they consult us in OPD only when it's something like an MMRC grade 4 or there is a drop in saturation and when you are supposed to admit the patient. So sometimes after exacerbations, some patients do prefer nebulizations for a few, like 1 or 2 weeks or 3 weeks. After that, we change them. Once their flow rate has improved, we try switching over to the inhaler. My according to that, if the flow rate is adequate and also keeping in the environmental consideration, it's always a DPI which is better because of the deposition which is there. But sometimes what happens in COPD patients is that you are not able to generate the flow rate. We are forced to use an MDI with spacer.
Sure. Sure.
Synchro
So, Atul, I'll ask you a sort of more specific question and maybe a more difficult one. So, suppose I am a 72-year-old man. I have got a 50 pack year history of smoking. You've taken a history. You've come to the inference that I have a overlap of chronic bronchitis and COPD. My FEV1 is at 38%, and I am breathless after walking 100 meters or less. My CAT score when I came the first time to see you is 25. So what would you do? Would you put in a variety of devices in front of me and try me on every single device and allow me to choose? Would you give me two or three and allow me to choose? What are the factors which will help you to decide this man deserves this device to start with? And how would you ensure that I have adequate flow rate, etc.? All the things you very specifically spoke about and nicely spoke about. How would you practically ensure that I'm capable of doing these things? Atul.
Before starting a DPI, sometimes what I ask the patient is if he is able to take a rapid breath in and if he is able to hold it for 10 to 20 seconds. I just make sure whether he is
Yeah,
able to do it. And sometimes I do have this placebo devices as well, which
sure.
can for such
Yeah.
patients. And
So the
so,
best thing, Atul, is to try and get the patient to take the device, use the device in front of you, and
yeah,
make sure they're capable of doing it. Isn't there's no other better test of
no, sure.
checking for inspiratory flow for that particular device, hai na? So that's probably the best. Yeah, go on. Very nice. After that,
So after that, that is how I prescribe. And as you asked about the breath actuated inhalers, I've been using that for a very long period of time. It is easy to use. It is easy to use if you demonstrate it properly. But sometimes what happens is many of them have that release valve at the posterior, the back side of that inhaler. Some of them just press it and the puff is gone. So that demonstration aspect is very important, even if you are using it in a breath actuated form. And there are higher end devices which are there, like your ellipta devices and all, which ensures a good amount of deposition, which is there even with a very low flow rate.
sure,
So basically, and another important factor is the how much the financial status of the patient as well, whether
sure,
he's
of
able
course,
to afford your high end therapies or he has that cost only for rotacaps or
sure.
so
So you
nebulization.
did not speak about the MDI or the spacer at all. Is that sort of
So I was coming to that. I use the
right?
MDI teaser in majority of my
Right,
patients.
right.
Frankly, it comes down to that because it is a slow and deep inhalation. Only problem is there are many patients who have Parkinson's and who have problem with
Sure.
coordination or holding the spaces, and in such patients we have no other resort than go into nebulization if they are
Sure.
affordable.
Yeah, very nice. So I think broadly you've heard. So probably elderly people, low inspiratory flow rate, the spacer and the inhaler is the best. I think Athul very nicely spoke about the fact that if you have sort of mechanical factors, so you have a tremor, you have Parkinson's, you have bad rheumatoid arthritis, you might need assisted spacer and inhaler, or you might want to try and resort to a nebulizer in those cases. The DPI, you just need to make sure that the patient has enough inspiratory flow, and doing it in front is useful. The breath actuated inhaler, I feel, is the future. It's easy to do. There's good drug deposition in these people. But the problem is very few drugs come in these devices. So your choices are very limited when you go for a breath actuated inhaler. And the last point, which Atul spoke about, very relevant, is the fact that cost also mandates what you use on a lot of occasions. So very nice. Let's move forward and go to the next one, which is for you, Nyrvan. Of all the inhalational therapy, and I'm specifically asking you about inhalation, I'll come to Ravi for the other bit. Is there an inhaler that we have today which gives you a mortality benefit? And for the audience, this is very important because that's your ultimate target. We've spoken about exacerbation being a hard endpoint. However, in any chronic disease, the hardest endpoint that you have by far is a mortality benefit. So, Nirvan, what's the evidence about inhaler therapy reducing mortality in patients with COPD?
Thank you, sir. Sir, this is a very nice question. So, and very pertinent to our topic. So, in terms of inhalers, the use of triple therapy has been proven to have mortality benefit. The use of LABA LAMA ICS has been proven in two major trials, the IMPACT and ETHOS trial, in a large number of patients, about 10K and 8K patients, in which they had seen that there is benefit in terms of mortality. But in this trials also, I would take the data with some pinch of salt because there are some issues with the reported outcome. Firstly, that the mortality, all-cause mortality in those patients was a secondary outcome. So the trials was not basically made to prove that it was a all-cause mortality. It was mostly to see the number of exacerbations in the next year. That was the primary objective. Secondly, is that in the trials which they had seen that the the amount of mortality was very less. So they had followed up the patient for about for a year, and the mortality rate was about 2%. So in the data of 10,000 patients and mortality of coming around 180 to 200 patients, in those data it will be a bit taking the data with some pinch of salt. And thirdly, if in those patients also, the trials took the patients who would respond to inhaled corticosteroids, such that patient who had a previous history of asthma, in those patients in which the data was used, so that the data might be a bit biased, but in terms of exacerbation rates and extrapolating the data to mortality, in those, I think inhaled corticosteroids can be used. So in the previous studies like the TORCH and the SUMMIT, in which they use LAMA and LABA plus ICS, there was the primary outcome was to check for all-cause mortality, but in those there was no statistically different. So, although these trials are showing statistically significant outcome with triple therapy, I would take the data with some pinch of salt, sir.
Sure, sure. So that's a lovely answer, Nirvan. You've proven yourself to be an astute researcher along with being a very good clinician. So I think a lot of facts that Nirvan points out is important here. So we are very happy that we have found drugs, inhalers, which now seem to have a mortality benefit. However, the word seem is important because the studies that were done, like Nirvan pointed out, were not powered to show that mortality benefit. It was powered to show exacerbations as a primary outcome. So that's why we are actually extrapolating the mortality data to an extent. However, I think it's which side of the coin you look at. Of course, if you find a mortality benefit, even an exploratory outcome, it means the drug does good. I mean, the TORCH trial became most famous. Of course, it showed a reduction of exacerbations, but it was the most famous p-value there is in all of respiratory medicine, where another mortality prevented would have actually shown a mortality benefit. So the p-value is more famous in TORCH as compared to the drug or the exacerbation benefit that the combination found. But I think we are happy that we are probably reaching to the point when we can do a trial in patients with COPD where you have mortality as a primary outcome. Those days are not far. Let me come to Ravi. Ravi, so that's about inhalation. The evidence with non-inhalational treatment, which gives you a mortality benefit, is probably more robust. So if you can cast some light on areas of therapy, non-inhalational in COPD, where you have a mortality benefit.
Well, definitely the all of these practices we commonly do in most of our COPD patients. I would just like to reinforce that they actually provide good reduction in mortality if you identify them correctly. Like Dr. Mansi and yourself had discussed, source control. So if you have an asymptomatic or a mildly symptomatic patient, then go down to source control and ask him to stop smoking. Smoking cessation is a very, very important and relevant intervention to reduce mortality. If you have a patient who has been hospitalized for an exacerbation in the past 4 weeks, then offering him pulmonary rehabilitation would be an excellent way to reduce his mortality. If you have a patient who is hypoxic, or who is having features of hypoxia like secondary polycythemia or carpulmonale, then offering him a long-term oxygen therapy will be very pertinent. More so if he has a PO2 of 55 or less than 60, then long-term oxygen therapy will be very useful for him. If you have a patient who is stable COPD, but at the same time having hypercapnia, a high CO2 value, then offering him non-invasive positive pressure ventilation at home would be offering him good reduction in his mortality rates. And suppose you have a patient with a low exercise capacity and predominantly upper lobe disease, then offering him lung volume reduction surgery would help reduce the mortality. All of these can also be called as types of severe COPD, but definitely these interventions will help reduce mortality.
Wonderful. So, पांच गिना दो एक बार रवि बाद में. So one is you said source control. Number two.
Source control. Then I told pulmonary rehabilitation.
Third,
I told home oxygen therapy, long-term home
fourth,
oxygen therapy, then non-invasive positive pressure ventilation
fifth.
and lung volume reduction surgery.
Surgery and therapy now, isn't it? You've got all the coils and the valves and all the fancy stuff, the sort of the thermal vapor, etc. Wonderful. So great answer. We'll move on. We've got about 10 minutes. So if I can have short, succinct answers for the remaining questions as we go along. I'll come to Mansi first. A lot of this has been discussed before, Mansi. But how do you position the SABA and the SAMA in your patients with stable COPD? Where would you put them? Would you use them at all? Or would you bin them like was what has happened in patients with asthma? SABA, SAMA, and stable COPD.
In my practice, I'm using mostly Sabasama as a rescue medication in COPD. For Gold A, people sometimes like to use, but for me, I think I would be rather happy using a long-acting drug in those patients also. And you have to use a dual. If you are using for rescue also, Saba plus Sama should be preferred, considering they have both different of actions and Saba has more of side effects. So the combination works better in terms of the adverse effects also. So monotherapy with Saba or Sama is not preferred as compared to a dual therapy I would prefer.
Yeah. So one of the things maybe to remember, agreeing with all of what you said, Mansi, one of the things to remember is if you're using a Lama and then you end up using a Sama as rescue, the response that you have from the Sama would be blunted to an extent because your Lama would be bound to the receptor for much longer and your rescue might actually not have the effect that you desire. So I think that's
Yes,
one of the things. It is not a contraindication to use a Sama, but it's something to remember when you don't get the response that you
absolutely.
would mandate. So I think that's something worth remembering. But the rest, I completely agree with you. Let me come to Nyrvan next. Nyrvan, there's a lot of trials now, a lot of interest in glycopyrronium. And one of the reasons why there is a lot of interest is the fast onset of action of glycopyrronium as compared to the other lamas that are available. So I wanted to ask you, is there, do you think, a role for inhaled glycopyrronium as a rescue? I'll sort of take that question a little further. When you look at bronchodilator responsiveness in your lung physiology lab, do you think you can use glycopyrronium rather than using a short-acting agent to look for a bronchodilator response in these patients? So where would you put glycopyrronium as immediate relief therapy or for lung function testing in patients going forward?
Sir, in our practice, mostly for exacerbating patient or in rescue therapy, SABA or SAMA are most commonly used. I would, in patients who are already on combinations of LABA-LAMA and LAMA in the form of glycopyrronium, in those patients, we would like to continue LAMA and add SABA in those patients as a rescue therapy. As sir, you have already mentioned that there is a very rapid onset of action. So in those patients, in case of pulmonary function test where we are checking for bronchodilator testing, maybe we can try for some trials where we can see that there is a data of how it fares in compared to our ipratropium or salbutamol, sir.
Yeah. So very interesting trials. So there's a trial which we are trying to design on this, Nirvan, and there's a lot of noise about trying to use single inhaler. So the smart approach in COPD, so single inhaler both as rescue and as maintenance. And you can think of formoterol and glycopyrronium as being the single inhaler both for rescue and for maintenance therapy in patients with COPD. It's something to look out for. But like you said, we've not reached there as yet. So we've not reached the stage when you say, okay, bin the SAMA, bin the SABA, we'll only use a LAMA in rescue and for bronchodilator response in patients with COPD. But we'll probably go there in the next 5 years, is what we are looking at. Exciting times. Let me come to you, Athul. Athul, inhaled corticosteroid. We've spoken about this at length, but I want you to give a couple of clear messages about inhaled corticosteroids in the management of COPD and a line about where you position eosinophils in your practice. I think we now know what Gold says, but how do you use eosinophil in your own day-to-day clinical practice so that the people listening to us can replicate what you do in their own practice? Atul.
Yes. So coming to inhaled corticosteroids, the indications have already been discussed. Like if you have eosinophil count greater than or equal to 300, or if you have a severe exacerbation admission. or if there have been greater than or equal to two moderate exacerbations, it warrants the use of steroids. If your eosinophils is between 100 to 300, you may use, but less than 100, it's a strict no. So coming to my practice, eosinophil count, I try doing it if the patient is admitted in exacerbations. But the problem with that is, at least in the place in which I practice in Cochin, there are a lot of allergic patients. There's a lot of allergic rhinitis patients, and if you randomly do some eosinophil count, also that might be more than 300. Not necessarily it should be a COPD patient. If you see randomly
Oh,
asymptomatic patients, when you are doing a as a part of your medical checkup, when you're doing a eosinophil percentage, that might be somewhere around 10% or 8%, absolutely asymptomatic. And secondly, triple inhaler, one more place where you can use is if there is an overlap syndrome. If there is an overlap syndrome,
absolutely.
and if there is an, as sir rightly told and in the beginning, if there's a predominant inflammation or there is an upper the bronchial involvement, and there is less of dyspnea but more of a cough variety, so those patients also we can use. And secondly, the thing is, if the patient is not improving on lava lama and there is recurrent exacerbations which are occurring, you can do an eosinophil count and try stepping up the inhaler to a lava lama and ICS combination.
Yeah, brilliant, Athul. So I think all the points that you make are very pertinent. I love the point you made about asthma COPD overlap. For me, when I sort of do a eosinophil count, for me it's actually most important for the gold B category of patients. Because for all other categories, for me, exacerbation is far more important than the eosinophil count. If someone is exacerbating, and I know it's a COPD exacerbation, I would definitely put them on an inhaled corticosteroid in trying to prevent exacerbations. So it's a stable patient who might exacerbate. And I think you made this point, Atul, even earlier in one of your answers. Uh, that's the category of patients when you want to identify high risk of exacerbation and prescribe the triple or sometimes the double in that category of patients. When I say double here, I mean the LABA ICS, which is seldom used, but I think we'll come to that a little while later. Let me come to Ravi next. Ravi, there's been a lot of controversy about parasitic infections. Atul just spoke about allergic rhinitis being very rampant. Do you think the eosinophil counts are different in our country? Do you actually sort of say we are 20% more than the global population as far as eosinophils are concerned and hence calculate? So is your cutoff 360 rather than 300, for instance, when you think of AEC? Or do you think eosinophil counts in our country are the same? Do you know of any data which is from our country? Ravi.
There is some data which shows that there is an average, means we do have our eosinophil count ranges in between 350 to 500 in several research papers that has been found in studies, with most commonly attributed to parasitic infections followed by allergic infections. So means it is very difficult for us in our respiratory patients to actually see lower eosinophil count. So maybe 100 would be a very difficult means criteria, because we, like Atul told, if you go out in your practice and do a survey, that at any given point of time you will get higher eosinophil ranges. So I feel that definitely, like other diseases, Indians too might be having a separate subtype to follow as far as eosinophilia is concerned.
Yeah. So there's two studies actually, and I'm struggling to get one published. We were over ambitious. We went for the Lancet, then we went for the New England Journal. So we have gone to chest now. So we hope it gets published. So there's about a 15 to 20% higher eosinophil count in normal subjects in our population of patients. The counts in COPD patients seem to be similar. In asthma, again, it's about 15 to 20% higher than what the global population is. But it is more likely due to allergic manifestations rather than parasitic infestations. So the increased eosinophil counts in parasitic infections seem to be more in the pediatric population rather than the adults. And once these people grow, the eosinophil counts seem to come down to normalcy once they've overcome this period of time when parasites infest. So I think it's still an emerging field, but probably slightly higher is what you would count. It will likely not make a huge difference when we are prescribing inhalational drugs for our patients with COPD. Let's come to Mansi next. Mansi, I touched on this, maybe a short message. Do you think the ICS LABA inhalers, just by themselves, so not multiple inhaler triple, but just the ICS LABA, do you actually prescribe them at all in your patients with COPD, or is it only for the asthma patients now?
So this used to be a common practice earlier, but now I think we should all evolve with time. And prima facie LABA ICS combination is not recommended for COPD patients by and large. So
Sure.
we should go for dual bronchodilator therapy in patients, or if we have to decide, we have to go for a triple therapy where ICS has to be combined with LABA plus LABA.
Sure.
So LABA ICS, some people may contest that there is a asthma COPD overlap. So it's rather better to own these patients as asthma and then give them LABA ICS, because obviously in an overlap with the criteria like you discussed about eosinophil, the criteria may not be very forthcoming in many of the patients. So a patient who behaves absolutely like asthma, in that patient, probably LABA ICS alone would do. But just if you talk of pure COPD patients, I think we should not be going for
Yeah.
LABA ICS
Yeah. So
combination.
I completely agree with you, Mansi. I think even in the asthma COPD overlap population of patients, you're obviously talking about people who've got fixed airflow obstruction, because otherwise they wouldn't classify into the COPD category at all. And in that population, I would rather give them a triple rather than giving them a LABA ICS in that population of patients. So completely agreed. I think LABA ICS probably is a vanishingly rare prescription. Just by themselves is a vanishingly rare prescription in patients with COPD. The next question I wanted, I'll go to Athul. Athul, triple therapy. We've discussed it at length. So I want you to give indications now. So 1, 2, 3, 4, whatever the number. What are the indications of triple therapy in your patients with COPD?
Right. So, firstly, my indication, according to Gold, all those, if he has recurrent exacerbation, or if he was admitted or hospitalized with an exacerbation. So that means even with inhalers, he is not improving. That is, initially, if he was on a LABA LAMA and he is exacerbating it again, that means we will have to increase it to a LABA LAMA ICS. Secondly, if his eosinophil count is 300 and you feel that there is an overlap which is there, and as you just rightly put in that you have to use a LABA LAMA ICS combination will be better in an ACO or a overlap rather than a LABA ICS combination. And these are so many of the times what happens is occurred in my practice. I get most of the patients in exacerbation. So after that exacerbation, I mostly put them on LABA LAMA ICS, provided that there are no other risk factors like a severe pneumonia or a TB or something like that. And secondly, if the patients are not improving on LABA LAMA, I'll automatically, and if he's exacerbating or if his breathlessness is worsening, I'll put him into a LABA LAMA ICS combination. And
So one
thirdly,
is exacerbation. What's number 2?
second will be overlap
Correct.
cases.
Correct. So second is overlap. What's number 3?
So number 3 is if he is not if his dyspnea is not improving. I'm not talking just about exacerbation. If his dyspnea is not improving, irrespective of using a LABA LAMA combination, then I feel as if you can try a LABA LAMA ICS and see whether he is not improving or not.
And especially the eosinophil count there becomes useful, Atul, isn't it? Especially if you have a
Category.
LAMA combination and then a eosinophil count which is above 300. There's good evidence now that adding in an ICS early rather than waiting for the first exacerbation to happen is useful. So that's number 3 in my book.
Yes, sir.
Anything else?
Fourthly, sir, in some cases, if they have a coexisting ABP or something like that, there are
Oh,
patients who
yeah,
have allergy, pulmonary
yeah,
aspergillus,
yeah.
and sometimes the patient will also have symptoms like an allergic rhinitis or something. So ultimately, they will always have a lung component which is there,
Yeah.
which later develop or might be in its nascency. So in such patients also, I try using a triple combination.
And then again, very last one, Atul, number 5 is your patients who have etiologies in non-smoking COPD where you have a predominantly eosinophilic airways. We spoke about this before, didn't we? So things like biomass-induced COPD, for instance, or your patients who have, I don't know, pollution-related COPD, environmental trigger causing COPD. So there you would do it. The only ones which Nyrvan pointed out where you're cautious are your patients with post-TB bronchiectasis and your patients with, post-TB obstructive airways disease and your patients with bronchiectasis. Let me go to Nyrvan next. Nyrvan, so I'll quickly ask a question to Ravi and then come back to you, Nyrvan. So question for Ravi is, there are certain drugs which are available only in an MDI. There are certain drugs which are available only in a DPI. There are certain drugs which are available in very limited numbers in breath actuated and not in others. So this limits our prescription to a certain extent. There's also this question about using all the new triples, for instance, are actually in a dry powder inhaler. Do you think this is a handicap? Do you think um, the inspiratory flow rate comes into question with these inhalers, and you should keep that in mind when you prescribe these drugs? Or do you think this makes no difference at all?
No, definitely, sir. What is important, I feel, is that these DPIs are easier to learn. There will be not a lot of patient coordination involved. Definitely, with even lesser coordination, the patient can inhale those drugs more easily. So these will be a relatively more sicker patients. So I think maybe because of the ease of use, I find that the only reason. Otherwise, I don't find any other reason that they might not be making breath actuated inhalers out of that. I,
Yeah,
I really am at a loss to find any other scientific reasons.
sure, sure. But do you think it helps? I mean, we are the company with the largest number of devices and the largest number of drugs in the world. Do you think it actually makes a difference in our prescriptions? Or do you think this is more a marketing gimmick, making every drug available in every device is more of a marketing gimmick rather than anything else? What's your thought, Ravi?
Well, sir, there is a fact that whenever you try to convince somebody for, a newer form of inhaler, they always ask you one question: what about that thing which I had in which I put my capsule? Most of the patients will be having that with them. And if you
Yeah,
offer them something which they can use in their pre-existing DPI, then they will take it up very readily. They only have to
yeah,
buy the medicine or the capsule. So it
yeah,
could be a marketing strategy, but at the same time, one easy thing is that the patients find it much easier to accept. And one more thing, which is that an expensive molecule, at least you can say, try it for once. We'll see if it doesn't work out for you in
yeah,
the next visit.
yeah. Grand. Very nice answer. I'll quickly do two or three last questions. I'll come to you, Nirvan, next, as I promised. So, single inhaler triple versus multiple inhaler triple. So, maybe an ICS LAMA in one inhaler plus a LAMA, that's multiple inhaler triple. And single inhaler triple, we have spoken about multiple occasions. Single inhaler triple once a day. What do you prefer? Does it actually change your prescription at all? How do you actually select between these two varieties, SITT and MITT? Nirvan.
Sir, regarding the different molecules, as it has been discussed in the previous question, that different molecules are available now. So I would like to keep my prescription to the minimum. So single inhaler therapy, and hopefully if it comes in a once daily and the patient is affording for that medication, that will be always my primary goal. So single inhaler therapy has been shown in the recent guidelines to increase the adherence. So always single inhaler therapy, and then unless the patient is already using some multiple inhalers, two inhalers in the form of LAMA ICS as well as another LAMA. So in those cases only I would continue with multiple, but single inhaler should always be preferable
Yeah,
in terms of adherence.
yeah. So the great answer. I'll just put a couple of caveats to this. So I have patients. I don't know whether you guys have or not, or the people listening to us, but I have these patients when I put them on a single inhaler triple with moderate to severe COPD. They tell me, doctor, I miss my inhaler in the evening. When it's 24 hours to the next inhaler, I feel that I am lacking a puff, and I need to take a levosalbutamol, for instance, or levosalbutamol ipratropium combination, for instance. And at there, I think doing a MIT might actually make more sense because you split the inhaler apart. So that's one thing that I think is important. The other thing, which is in line with what you said, Nirvan, is that people actually find single inhaler triple therapy very useful. It makes people mobile. It is easy to carry. Most of these, as Ravi said, is dry powder inhalers. Hence, you don't really have to carry the cumbersome spacer along. You can do the inhalation discreetly. Uh, Lots and lots of benefits. And I agree with you that a lot of the conversion from dual multiple time inhalers has now converted to single inhalers, which is far more convenient. Couple of questions quickly about about nebulization. So I'll come to Mansi first. Mansi, what percentage of your patients are on home nebulizations long term. So we're not talking about a short spell of nebulization at home. We are talking about maintenance long term nebulization for more than 3 weeks. What percentage and why are their home nebs?
So, in my practice, home nebulization, I think it's very important aspect of management. Especially, we have a huge pool of patients who are above 70, and a lot of them have multiple morbidities. So, any patient who will not be comfortable using inhaler in terms of the coordination or the technique, and they are, and believe me, education of the patients not sometimes that great. So sometimes they are not able to learn the thing also. So people may not have support at home to supervise it. So by
I think we have lost Mansi again. I'm sure she'll be back in a moment. I think, yeah, sorry,
so
Mansi, we lost you
cognitive,
for 5 seconds again. So,
yeah, sir. So elderly population, those people who have cognitive issues, who have neurological issues, they can't hold or joint issues. So sometimes they are not able to do the inhalers well. Those patients, I am giving home nebulization beyond 3 weeks also. And certain patients who have advanced COPD and they are not getting relieved with usual doses of inhalers. So as an add-on, home nebulization is being added to the treatment where you can step up the doses of bronchodilators when needed. For patients who are having their end of life support and COPD is a comorbidity, again, needless to say, these people will be also on home nebulization because inhalers are not the option for them.
wonderful.
Yeah.
So, very nicely, very lucidly described indications for home nebulization. Let me come to Hi Krishna Bhai. Good evening. Such a pleasant surprise to see you. Thank you for coming and dropping in again. Um,
भाई सीसीए खान कलकत्ता में तुमसे नफरत में थोड़ी लूंगा.
So I'll come to you in a moment, Krishna Bhai. We'll definitely love to have a comment from you. I'll just go to Ravi first. Ravi, we have these patients who are on nebulization in the hospital during an exacerbation. You need to send them home. When you send them home, do you have a period of overlap in some of them where they do nebulization for a few days and then you move them to an inhaler follow up? Or do you sort of follow the dictum? No. Before going home, everyone who's on a neb and was previous to an inhaler goes back on an inhaler. What's your attitude? How do you do it, Ravi?
Well, sir, there are some considerations like Dr. Mansi told the patient's physical and cognitive ability, whether he'll be able to take anything else than a nebulizer or not, whether he'll be able to manage that device safely or not. What is the nature of the exacerbation? Is it a very severe exacerbation or is it as a mild exacerbation? What is the patient's preference? Does the patient want to continue on nebulizer more because he feels a little more comfortable with it, or he's okay in changing over
So
to an
that's something I'll stop you on. I'll allow you to complete your answer. But this is the largest category of patients where patient feels, no, I feel better on a nebulizer. So my attitude there would be to actually sit and reason with the patient and find out whether it's just a psychological dependence or it is actually something which improves his quality of life or his lung function for that matter. Do you do that or do you sort of say, no, you feel better on a nebulizer? Let's keep you on a nebulizer.
Well, it all depends on, sir, how long has his admission been, how comfortable he is actually after 2-3 days of treatment. And if he is actually managing quite well, expectorating quite well, then I would like to advocate my case for changing him over to an MDI or a DPI. But at the same time, if I see a patient who I know needs 7 to 10 days more of treatment, higher treatment, then I wouldn't argue with him at a lot and let him go home with a nebulizer.
Sure. Okay. Fair
But
enough.
yes, patients who are admitted tend to be more comfortable with nebulizer. It is sort of, they have that teddy bear effect with the nebulizer. They are very cozy with it and feel safe relatively. One
Yeah,
more thing is financial considerations because
sure.
many insurance companies won't be supporting the nebulization device. The medicine is okay. And then accessibility. Suppose you advise somebody who is living in a remote village, you advise a nebulizer. At times, they have actual problems with electricity and finding access to
Sure.
doctors or clinics who nebulize. In them, we have to change over to DPIs and MDIs. So that these are the few points which we consider.
Sure. No, absolutely fair. I'll sort of summarize what you said, Ravi. The fact that there is a cohort of patients where you would have a period of home nebulization post an exacerbation after going home before you change them to an inhaler. my understanding of the evidence available is that a lot of evidence about inhaled home nebulization is actually extrapolated from the DPI, MDI, breath actuated inhaler evidence. There's no direct evidence. We know this greater drug. Because this greater drug, the incidence of fungal infections is greater with a nebulizer as compared to what you have with an inhaler. The chance of the accessories getting infected and causing an infection is greater. There's more amount of cleanliness, hygiene that needs to be maintained with the nebs. So I would try and spend some time in trying to make sure that your patient merits the nebulizer at home long term. You're not talking about short term, you're talking about long term, and deserves the nebulizer. And then you say, okay, this is not psychological dependence. The lungs are better, the symptoms are better, the lung function is better, and you convert them after. I think it's about 20% of my population of patients with COPD who are on home nebs, which is a higher number as compared to what I had 5 years ago. So even I have increased the number of prescriptions in my practice. A quick answer, Nirvan, before we go to sort of home taking comments. So, nebulized drug would you use in an acute exacerbation of COPD? We have done this before, but maybe some headlines about what drug you would use and the reasons for the choice quickly.
Sabasama is always it is easy to administer, so it is preferred generally. But in cases where Sama cannot be used, suppose the patient is on LAMA, patient has a history of urinary retention, patient has a history of renal failure, because they are quaternary ammonium compounds. So in those patients only Saba should be preferred. Rest, if regarding the accessibility as well as easy to administer, Sabasama should be preferred in excel.
So Sabasama, what about inhaled corticosteroid during an exacerbation, Nirvan?
Sir, inhaled corticosteroids, as we have discussed, that inhaled corticosteroids have the recent data which has come versus the use of systemic glucocorticoids. The inhaled corticosteroids are much better to be used, so it has improvement in patient symptoms as well as reduces the glucocorticoid doses.
So inhaled corticosteroids, even as an add-on, along with systemic steroids, actually reduces the duration of hospital stay and reduces the morbidity of the disease process, is something which is worth remembering. Before we go to carry home message, let's quickly take a couple of questions. All the questions seem to have come from my good friend Dr. Tridip Chatterjee. There's a question which I'll take to Ravi. Ravi, newly detected COPD with FEV1 of less than 50% on diagnosis. Will you start them on a single dose inhaler, which is a single inhaler triple, or would you give them twice daily inhalers and then change? So the question he's asking is a very important one. So post an exacerbation, would you go straight from nebulized drugs to single inhaler triple therapy once a day, or would you feel more comfortable by giving inhalers twice a day or thrice a day and then going to single inhaler triple when you maintain stability for over a period of time?
Well, I would definitely, if the patient is recovering from an exacerbation, prefer to give it twice or thrice a day, and then only change over eventually to once a day. For the simple reason that we want to maintain a higher level of bronchodilation so that the patient recovers earlier. And like you very well told that if he misses one dose in the evening, he might be running helter-skelter for another dose. So it is much safer that you give it 2 or 3 times a day initially.
Yeah. I agree with you, Ravi. I think that's a great question, Dr. Tridipda. And the fact that using twice a day or thrice a day inhaler to start with and then graduating to a single inhaler triple is also what I do in my practice. There's a lovely question from Dr. Harendra Thakkar. I'll take that to Mansi maybe. Mansi, MEPO in the use, mepolizumab in COPD exacerbation. So I'll broaden the horizon a little. Biologics in COPD exacerbation. I mean, we are talking theory here. I don't think a lot of us actually use it in labeled COPD. But what is the benefit? Where would you consider it even if you don't use it in your clinical practice? COPD exacerbation, use of biologics.
I think his question is coming from the fact that recently there was data showing that biologicals can be used during an asthma exacerbation. Prior to that, things were being used only in stable states after the patient is not controlled on the usual pharmacotherapy, including high doses of steroids. So similarly, there is no data about mepolizumab per se in COPD exacerbation till date. But yes, there are studies in stable COPD that mepolizumab is being used just like other biologicals and being an anti-IL-5. So, but the data is more forthcoming for dupilumab. That
Correct.
is why even Gold has accepted dupilumab over and above mepolizumab. So I think
Yeah.
mepolizumab you can give at your own discretion depending on your patient profile. Maybe a
Yeah.
patient of asthma, COPD overlap, that kind of a patient.
Yeah.
So it's a personal choice right now. Yeah.
Yeah. And just as a message, I think, Mansi, coming from all of us, it's for a very, very select group of patients. It should not
Yes.
be something that you do
Biologicals are
often.
for select group of
Yeah,
patients
correct.
after deeper evaluation.
Especially in COPD. I mean,
Yes,
especially in
especially
COPD, it's going to be a very, very small cohort of patients who actually benefit from the drug and should be given after great caution and discussion. There's another question which Tridipta has asked, which is Gold E patients on triple, given on the basis of a CAT score, eosinophil count, would you try to reduce triple inhalers to LABA plus LAMA in all patients or only in elderly patients with diabetes? And how would you place lung function? Again, a great question. Let me take this to Nyrvan. Nyrvan, so the question is, you're in a triple. You're happy, exacerbation free, say for a period of 9 months. You've had no exacerbation. Symptom control is good. Would you try and step down on ICS? Would you try to take the off the ICS altogether? And what would mandate the decision if you decide to do so?
Sir, it will always be preferable to continue the LABA LAMA ICS therapy. But if in case the patient has some amount of complications due to ICS because it has been related to osteopenia as well as the incidence of the pneumonia has been seen to be increased. So in those cases only I would like to consider to convert to LABA LAMA combination.
Sure. So, a couple of things. So, I agree with everything that you said, Nirvan. A couple of things I would like to add from my side. So, this is another place where I find doing a eosinophil count very helpful. So, if you have someone on a triple and you manage to find an absolute eosinophil count of less than 100 and no exacerbation for a period of 1 year, I would at least try and come down to the lowest possible dose of inhaled corticosteroid. Even if I was between 100 to 300, exacerbation free for a period of 9 months to a year, and I find that the quality of life is good, I would like to come down on the inhaled corticosteroid as much as possible. But in most of my patients, I wouldn't take the inhaled corticosteroid off completely. So, lowest possible dose, but not off completely, is what I would do in that category of patients. Atul, I'll come to you with the last question that I have from the audience, which is again from Sudipta. So, inordinate increase in pH in COPD should make you check for OSA or pulmonary thromboembolism. So, I think one he's talking about um, pH reduction in the way of respiratory acidosis. The other he's talking about um, uh, worsening in the way of metabolic acidosis from pulmonary thromboembolism. You think of these diseases, when do you think of them? Very, very briefly, Atul.
Yes, sir.
Sir,
So
I think he wanted to say about pulmonary hypertension. That is what I think he meant.
Says
PH.
PTE though in the table, but yeah, yeah. So let's do both. Let's quickly do Atul
Yeah.
PTE. When do you think about it in your patients with COPD, mild, moderate, severe, and also about pulmonary hypertension?
okay, sir. So PE, the thing is, if the patient is presenting to you in an exacerbation, and secondly, he has tachycardia or something, and you find signs of a right-sided failure in him. And ECG can be pretty helpful in such cases. Patient might have a tachycardia, and he might have those changes from V1 to V4 in which there might be an ST elevation or a T wave inversions which are there, and he might have a poor R wave progression. S1Q3 T3, although we say it's a classical finding, many a times what we always find in pulmonary embolism is that there is a tachycardia and all those changes in V1 to V6 or V1 to V4. And secondly, an echo will also be helpful in such cases in which we look at the right side of the heart to look for whether there's a right ventricular dilatation. And thirdly, one more point is even when we are talking about PE and when we are talking about the management of PE, if it's an intermediate risk, we always look at two lab markers. One is the pro-BNP as well as the tropi. So if that is also, and if all these points are coming towards and you always, because um, a COPD patient can have a lot of not just pulmonary embolism, a lot of cardiac conditions like tachyarrhythmias or atrial fibrillation or multifocal atrial tachycardia. So that is how you can suspect a PE. And secondly, coming to the pulmonary hypertension point of view, and sir actually asked whether there's OSA or PTE which is going into a PAH. So whenever, as I told, whenever you are following up a COPD patient, I think it's always important to take an ECG and see, not
Sure.
just for not just for the embolism point of view, also looking for the signs of any right heart strain in that. Do an echo, and if there are symptoms suggesting of your obstructive sleep apnea, always do a sleep study as well. And one more thing I also point want to point out is always rule out other causes of COPD as well, and not just COPD, whether there is any other underlying condition
Sure.
as well, like doing an HRCT thorax or ruling out any ILDs which are there, which is contributing to pulmonary hypertension. So,
Sure.
and see, I think many a times you can pick up from the body composition of the patient, the history
Sure.
of the patient.
Yeah.
And there are patients who have that syndrome X and all that, in which there is
Sure.
OSA as well as a COPD, and there is a compounding of the pulmonary hypertension because of your hypercapnia as well as the hypoxia which is there. So they might inevitably need a BiPAP or
Sure.
support.
Yeah.
So you're right.
So wonderful points, Athul. So couple of things I would like to sort of add from my side, simple points. So if I have someone who's got mild to moderate COPD, comes into hospital very breathless, tachypnic, hypoxic, I do a chest X-ray and I find no acute changes. Mark my words, no acute changes on the chest X-ray. And I find a PF ratio which is below 200 in the background of mild to moderate COPD, I would think of a PE in that category of patients. That would be one of the important differential diagnosis in my mind. So clear chest X-ray, hypoxic, tachypnic, breathless, with no obvious explanatory factor for the breathlessness and the hypoxia. Interestingly, there's good data, Atul, which shows that if you have pulmonary hypertension, which is moderate to severe along with COPD, you actually get type 1 respiratory failure rather than getting type 2. So you don't actually get hypercapnic if you have moderate to severe pulmonary hypertension. And that's one of the important things you pick up on the ABG. You do a ABG, you find that the patient has type 1 respiratory failure. Although it's a follow-up patient of yours, it's someone with COPD, it might be the pulmonary hypertension getting worse, which has caused the patient to get into hospital. And the OSA, like you said, Atul, the body habitus of the patient, the fact that you just not being able to correct the respiratory acidosis, the hypercapnia seems profound. The baseline set CO2 is higher than what you would predict. You think of OSA in these individuals, and that's a common overlap, like you said. So great discussion. We'll come to sort of concluding remarks in a moment, but I would like to sort of call back Krishna Bhai for some comments about inhalational therapy in COPD, about its thoughts about the meeting today. Krishna Bhai.
Namaste, Raja Bhai. You know, I'm a layman. I'll speak like a layman. Okay, initially, the choice of the device, that is very important. We have so many people who visit us who proudly present us that they have a nebulizer at home as if they have CPAP or probably a lung transplant device at their home. So they will tell us, they will come and tell us that they have a nebulizer at home. That proudly they tell us. So actually, basically speaking, I should not quote this, but a very famous hospital in Karnataka, for such respiratory thing is dealt by a different category of people, not pulmonology. And take home, they rate nebulizer to everyone. So they proudly tell you that as if they have something great in their house. So it comes to the choice of devices, even for bronchial asthma or COPD, that what do you want? As you all know, there are DPIs, there are MDIs, there are MDIs with spaces and with baby mask, and there are synchronized breath in actuated devices, and you also have nebulizers. So which do you want here is the first question. And why do we do a spirometry at all then if we cannot differentiate with the spirometry that what he can do, what we are supposed to write? We can make out in the spirometry the expiratory and inspiratory, everything. So we can also make out the age, at which age the patient has come to us. You know that geriatric are equal to pediatric. At times they may require baby mask also. So the exact device which you want to prescribe to the patient is very important here. I have seen that actually it is a fact that 80% of the market is with DPAs and 20% is only with inhalation. Nebulizers are like, no, they are like proud stuff being in their house. And they do tell us as if they have got their, and they tell us not nebulizer, sir, we have got the oxygen device at our house. So it's all like, it's like that. But however, I tell you that the exact choice of device is very important. If it is DPI, fine. If it is MDI, then we need to think which MDI it is. And MDI with spacer or without spacer, with baby mask or without baby mask. Nebulizer is something, as Raja you told, I heard that nebulizer is something definitely opted whenever it is very important. But however, how important nebulizer that we should think of. And if nothing helps, only nebulizer comes in the picture. Nebulizer is not the first choice of administration. That's because I wanted to be very specific regarding the choices.
Yeah.
You all have spoken the Oxford. I am speaking regarding my university.
No, I think you're being modest, Krishna. I think very, very pertinent points. I think the devices we spoke less about. And I think the points that you make are very, very important, very pertinent, as important as the drugs that we spoke about. So we'll come to final comments and we'll start off with Manasi in a moment. Before that, while Krishna Bhai is there, I'm proudly hosting CCI Con in Kolkata on the 22nd to the 24th of August. And a very warm invite from my side, from entire team CCI Con, for you to come to Kolkata. This is your conference. It's our conference. It's for all of us. So please come in large numbers, make it a success. It's only your coming to this conference which will be a success. If there's any problem with attending, if you're not managing to find support, please do write to me and I'll try my very best to find you pharma support. But do try and drop in and be there with us for the 3 days. And we promise you that you will have an academic and a social occasion of a lifetime. So
Raja, your email ID, please, to the public, to everyone, your email ID.
I will share my email ID on the chat. I mean, even if I say it, it probably doesn't make any difference.
There are public watching here. It will be uploaded on also on YouTube channel.
So, yeah, chat box. Is it visible to the public? I don't think it is.
No. I'm talking about the public which are visible.
Sure. So, how would I share my email ID to the public? You want me to say it out? I have no problem.
Yeah. You say it out.
So it's DocRD. So it's DOC AAR DEE DocRD at yahoo.com. So write to me and we'll try our very best to make sure that you travel down to Kolkata for our conference. And I would personally be very happy if you did that. So let's then come to final comments. And I'll start off with Manasi. Manasi, what's your one take home for the meeting today? What is that one message? Stay till the end. Krishna Bhai will be there for 2 more minutes. So stay with us till then. Okay. One comment from you, Manasi, which is take home for the audience today. You're on mute, Manasi.
One thing that you have said when we were ending the discussion, that step down of therapy is possible in COPD because many of the patients start after exacerbation with the triple therapy. So try and aim to bring it down to bronchodilators, and it is possible in certain patients.
Absolutely great message. So step down is not just for asthma, it's also for COPD, and with steroids, it's become a reality. Let me next come to Nyrvan. Nyrvan, your one message for the audience today to take back.
Amongst the inhaled therapy, inhaled steroids are very important in preventing exacerbation. So, judicious use of inhaled corticosteroids is always important in treating COPD patients.
Yeah, great message. I really love the word judicious there. I think that's the one you underline or highlight. Judicious use of steroids in patients with COPD is of utmost importance. I'll come to Athul next. Athul, your carry home message, one message for the audience today.
Yes, sir. So COPD, I think we have talked a lot about all the inhalational medicines and everything. Other thing what we always should do in COPD is to early identification of comorbidities, especially cardiac comorbidities, and also take into account the psychosocial support of the patient as well as the nutrition of the patient. Many a times what we always miss out is to counsel them regarding the right nutritional support through a dietitian or something, whether any supplementations are needed. So, along with inhalational therapy, all these factors, along with smoking cessation and your pulmonary rehabilitation, your psychosocial support, as well as your vaccinations and your nutritional support, is equally important in COPD management as your inhalers are.
Great message, Athul. So the non-inhalational bit is what Athul focused on. Very, very important to do that in a country like ours, where there are 55 million COPD patients, probably closer to 60 million. We form the greatest burden of COPD in the world. We form the greatest number of people dying from COPD in the world. That's a very strong message, Athul. Ravi.
I strongly feel after this webinar, one very important thing that it is shared decision making, which is most important in between the patient and his physician. It shouldn't be a unilateral dictatorship where the physician says, ye lena hai, ye lena hai. You have to hear out your patient and his and adjust according to his requirements. It has to be a tailor-made prescription rather than a protocolized prescription. And please don't advise anything that you don't know how to use yourself.
Yeah.
That's
Yeah. So I'll extend that, Ravi, a little as my message. So I think in any chronic disease, we are discussing COPD today, but in any chronic disease, especially one which involves inhalation, there's a lot of stigma attached to the process of inhalational therapy. And it's your conviction as a physician that gets transferred onto the patient. So unless you speak to your patient, communicate with them, unless you transfer your confidence and clear the myths that are there in their mind about inhalational therapy, you're never ever going to get the patient to comply. And the device and the drug is as good as the patient taking it. If the patient does not comply with your instructions, you have failed in your duty and the patient does not get better. So I think that's my shared message with Ravi and everyone else on this panel. Spend time with your patients or get someone in your team to spend time with your patients. Make sure that their doubts are cleared. Make sure that the myths are busted before you go on for any inhalational therapy in COPD. That's our composite message. Dr. Shabhai, before we depart, any last word from yourself?
How will you go from here?
How
First
will I go
question.
from
You
here?
can walk.
Correct.
Okay. You can take a cab, auto, or you can bicycle yourself. You can take any way to go home. So that is very important regarding the choice of devices. So it has to get administered, but how it should, as I told earlier.
Yeah.
And for me, the take-home message is very brilliant. It is like, no, I assure to everyone who's watching this, because even in YouTube channels will get uploaded, and thousands will watch later. The CCI Con Kolkata happening will be the biggest ever CCI Con held till date. I assure that. I know Raja. So kindly do join us August 22 to 24 over there. And we are launching the website in 2 days. Raja, I was very busy regarding the same conference calls. So
Sure.
that's why I joined late.
No worries,
So it's
Krishna
good.
Bhai. Thank you for doing the
It's
hard work.
happening.
And echoing what Krishna Bhai said, look out for the website, register on the website. Need any help, write to me. Write on the website itself. There'll be messages that you can post on the website for all of us. And we are there to welcome you to Kolkata. Thank you very, very much, guys. Absolute pleasure talking to all of you. Ravi, Nyrvan, Athul, Manasi, all of you were absolutely brilliant. And a big thank you to Krishna Bhai for dropping in as he always does for my CCI Con webinars when I do them. Thank you, guys. Good night and stay well.
Thank you, sir. Good
Long
night,
live
sir.
CCA. Jai Shri Krishna.
Thank you.